Okay, I think most of our folks are in right now. So we'll go ahead and get started. So welcome to our webinar. I'd like to introduce our presenter, which is Heather MacLeod. Heather is a certified genetic counselor who started her career in cardiovascular genetics at the University of Chicago and has experience implementing cardiovascular genetic clinics at Sibley Heart Center in Atlanta, as well as for a telephone-based genetic counseling company. She's the senior project manager for the Sudden Death in the Young Registry, where she has been helping to develop and implement the registry for 8 years now, since 2013. She is actively involved with projects through the National Society of Genetic Counselors, Cardiac Special Interest Group, and serves as a scientific advisor to the SADS Foundation. In honor of Family Health History Month, we bring you this webinar, What's in Your Genes? Who Gets Tested First? Sharing with Your Family. So it's my pleasure to have Heather MacLeod present this webinar as a SADS Foundation scientific advisor and volunteer. We'll have time for questions at the end of Heather's presentation. And if we don't get to all of the questions tonight, you can watch further details of a future webinar on genetics in January. So watch SADS social and emails. And now I'll turn it over to Heather.
Thank you so much, Jan. Welcome, everyone. It's my pleasure to be here and present kind of a genetics primer for as we wrap up Family Health History Month for November. So I got the fun title of What's in Your Genes? Oops, let me just make one adjustment. There's a number of questions I want to cover tonight, including who gets tested first, and how do you share information with your family, which could be at the front of your mind after having seen your family over Thanksgiving or having been talking to them as you go through this process. So the objectives I'd like to cover is to understand the current tools to study genetics, how to locate a genetic counselor, identify information to collect from family members, understand why genetic testing is helpful dealing with a SADS condition, and identify family members that may also be affected or at risk. So the current tools for studying genetics, these probably won't be a surprise to you, but our family history, this is the cheapest and oldest genetic test we have, is knowing your family history and what different diagnoses and events people in your family have had, genetic testing, and then family screening, which by that I mean having different members of your family in terms of a SADS condition, seeing a cardiologist or an electrophysiologist to see what diagnoses or different symptoms they have through EKGs, echoes, and other electrophysiological testing. So in terms of what tools are available in genetics, there is a whole allied health field dedicated to helping families understand their family history and genetic testing. And these professionals are master's trained in both genetics and psychosocial counseling, and they're called genetic counselors. And so what they help you with is there can be a lot of big feelings that come up with going through this journey of having a SADS condition. So they provide psychosocial support. They can help you collect your family history, collect of genetic testing, help identify which family members need to be screened, and they can help facilitate finding experts in their area, coordinating with different physicians and sometimes medical examiners if somebody has died from sudden death, facilitating genetic testing and or DNA banking, which is saving a sample, helping you send a family member letter to family members, and then referral to additional services as needed. If it's more psychosocial support, or if it's talking to somebody about having a defibrillator, there's a number of different support services that a genetic counselor can put you in touch with, including working with the SADS Foundation, but you've already found them, so you're on the right path. Questions you should ask your family members about include sudden death. Has anyone had a heart attack? This can sometimes be cardiac arrest, but in layman's terms, people can think heart attack. Fainting, which medically is referred to as syncope or near fainting, pre-syncope. Anyone that has trouble exercising or exercise intolerance, seizures, any unexplained drownings, unexplained single motor vehicle accidents. This is something we look for particularly in SADS conditions because someone could have had an arrest while driving. And so it might look like they were just, it wasn't snowing, it wasn't dark, they weren't sleep deprived, but they ran off the road and hit a telephone pole. And we are suspicious of those based on the diagnoses we are dealing with. SIDS or SUID, so sudden infant death, can be an indicator of having a SADS condition in your family. With ARVC being part of the SADS conditions, anyone having an enlarged heart or cardiomyopathy, anyone with a defibrillator or a pacemaker is of interest. With some of the more syndromic causes of long QT, deafness is important to note in your family history, as well as syndactyly, with having some of our families having Timothy syndrome, which is a more syndromic version of long QT. To further gather information on families, collecting medical records helps verify different conditions folks report. So collecting medical records to verify previous diagnoses, medications, genetic testing. If someone died, getting a copy of their autopsy. Sometimes we dig even deeper and look for pre-operative evaluations to see if somebody might have had an EKG before they had an operation, or before they were prescribed ADHD drugs. Any ER visits or chest x-rays can sometimes also provide additional information. So in genetics, we use this graphic illustration of families to help us have a snapshot of a full family on one page. We use squares to denote males, circles to denote females. So in this picture, you see a father, a mother, and 4 children with an arrow at one of the boxes, and that indicates, oops, I skipped ahead, indicates that that person is affected with the SADS condition that we're interested in learning more about. Typically, we like to get a 3-generation pedigree. So you'll see like the grandparent generation, the parent generation, and the child generation. This is standard. And this just helps us put all of that information we were just talking about, the diagnoses of interest, the medical records, and eventually I'll talk about the genetic testing, all onto one picture to best represent your family. So I wanted to go really basic because I don't know exactly where people are starting from, but I think this is helpful to know in terms of genetics that humans have between 20 and 25,000 genes is what we've learned from medical research. And genes are the instructions for how our bodies grow and develop. Most SADS conditions are genetic and inherited in an autosomal dominant fashion. So it just takes one copy of a gene passed down from one parent to child to have a genetic diagnosis of a SADS condition. So when you think about your family, it's important to think about who is the most informative person to test. And it's actually the person with the diagnosis. Because genetic testing is not perfect, the test, so say you get tested for long QT syndrome, we cannot detect 100% of cases of long QT syndrome with genetic testing because we don't know all the genes and all the genetic changes yet. So in order to have informative genetic testing, you need to test somebody who either has a diagnosis or the person who has a suspected diagnosis first. If you have multiple people in your family who are affected, it's best to test the youngest person in the family with a diagnosis or the person with the most severe disease. Somebody that's had an arrest and has a defibrillator is the best option compared to someone who just has a slightly prolonged change on their EKG. What is the process for genetic testing? I'm just going to go over generalities with this, but the type of sample is typically blood. In some cases, it's a cheek swab, so the Q-tip in the mouth. The cost will vary based on the lab. Costs can be as low as $300 for genetic testing at this point. Your genetic counselor and your physician can help you identify a lab. There's about 4 labs that do the majority of the genetic testing for SADS patients. And in some cases, if there is difficulty with payment, there is something called sponsored testing where your information might be shared for future research, de-identified testing, but then your testing is at no cost. So Alice and the SADS team can discuss that more during the questions if folks have questions on that. It's also important to think about what test is sent. So if the genetic change in your family is already known, you can get tested specifically for just that change because you already have the marker in your family. This is very inexpensive to do, and it's considered a targeted test. We used to do single gene testing. We're way past that, and we're moving on to panel testing. So it's typically 30 to 40 genes are tested at this point, depending on the lab. There's even bigger panels that are looking at both arrhythmia syndromes and cardiomyopathies, or arrhythmia syndromes and epilepsy genes because of the overlap between seizures, arrhythmias. And then in some cases, folks have exome or genome testing done. And this is looking through the entire genome, both the coding and non-coding regions, and reading through 20,000 genes, not just 40 or 50. And so there is a lot of information, and it is recommended to go to an expert center with the different types of genetic testing. It's hard to sort through the results on your own. So if you have a diagnosis of an arrhythmia syndrome or ARVC, you're like, wait, I already have a diagnosis. What do I need this test for? If the results come back positive, it gives you more information on your disease. It confirms the diagnosis that you've been given. So, for example, if you have long QT and the genetic testing comes back positive, it will read pathogenic or likely pathogenic variant identified. We used to say mutation, but the language has been updated to pathogenic or likely pathogenic. So it will confirm your diagnosis. It will tell you what type of long QT that you have, which is helpful for knowing what potential triggers could be most dangerous to you. It can help tailor your treatment in terms of what type of medication or if you need a device. And it provides an easier tool for family members instead of every year or 2 years going to see a cardiologist to see if their EKG has changed. If there is a known genetic change causing disease in your family, they can have a simple blood test and know if they are officially at risk or not. So it can simplify the process for family members. So as I mentioned, the possible results are pathogenic or likely pathogenic, which we used to refer to as a mutation. There are a large number of variants of uncertain significance. This means that there is a genetic change, but based on current knowledge, we don't know if it's disease causing or not disease causing. And then you can also be negative. My experience recently is that based on the number of genes that we're testing, very often people come back with at least one variant of uncertain significance. I wanted to share how to read a test result. If you've already had genetic testing, it will look like hieroglyphics because there's a number, there's like a code in terms of your results. And it will follow this pattern. It will have the gene name, the C period is the nucleotide change. So the genetic alphabet is A, C, G, and T are the letters that we're reading through. So I gave an example here. So SCN5A causes Brugada and long QT type 3. So the nucleotide change at position 3745, a T changed to, sorry about that, a T changed to a C. Then it lists the amino acid change. So this is the protein change. And in this case, in this example, is a phenylalanine to a lysine. And this is super important for your care team to know. It's important information for your family to know when they have their diagnostic testing. This is the money sentence in your genetic test result, what they need to know. So I brought up genetic counselors in the beginning, and one of the really key points as genetic testing moves forward is that interpretation is king. There are a number of different databases and different tools that we use to get the results back from a lab and best understand what the genetic change means. And so it's super important to work with someone that can help you through that. We don't expect you to work through that. There are a number of variants of uncertain clinical significance, and these classifications can change over time. So it's helpful to stay in touch with a genetics professional. So if something gets reclassified, you know when that is. We find new information about genetic diseases a lot. There's a lot of research going on. And so it's important to know if your testing 10 years ago was not informative, when should you consider getting tested again? Because things do change and tests change. So I put on this pedigree or graphic of a family history, just how I would update it. If somebody had genetic testing, you'll see the mom in this pedigree. I'm hesitant to use my pointer because it keeps flipping my slides forward. But you can see the parent generation, the mom tested positive. And I would put on the pedigree what her specific mutation was. And the child tested positive and has a diagnosis of long QT3. And this is just how we keep updating your family history and your pedigree to reflect what's happening in your family. We can also use this information to look down and know that this other son is affected and should be tested. These two daughters down here currently are asymptomatic, but knowing that the mom carries the pathogenic variant, we should test them to know if they should continue medical surveillance, seeing the cardiologist, or not. They could come back as a negative on the specific genetic change, and we wouldn't need to follow them as closely. Knowing that the change comes from the mom's side, we also now know that her side of the family is at risk and needs further follow-up, as well as any children through these aunts and uncles over here. So how do you share this information with your family? I think this is very personal depending on the communication patterns within your family. Some people will want a phone call. In addition to a phone call, it's very, very helpful to have this information in writing because it's a lot to absorb. I don't know how much you've absorbed tonight from me talking, but I'm going to also send out a copy of my slides so that if you want to go back, you can reread. So in some families, a letter is most welcome, and other families an email or a text with the information. The SADS Foundation has information on their website, a template, so you don't have to come up with how to do it on your own. But it is really important to share this information with your family because you've done a lot of homework and discovery getting this far. So to help them through it and make sure that they have the most information is important too. I also wanted to quickly touch on what if the results are not informative. Like I mentioned, over time, you might consider getting retested. There's also a number of research studies ongoing. The timeline for results, typically with diagnostic genetic testing, sending your blood out to a lab, results will come back in 3 to 4 weeks. With research testing, the timeline is unknown. And if someone in your family has died and their blood sample is with the medical examiner and your family is not ready to pursue testing, there is a resource called DNA banking, where they take the sample, extract the DNA, and then the DNA is available to your family when you are ready to use it. Questions? I'm going to ask for my SADS friends to let me know what questions have come up.
Yes, Heather, I'll put in the notes about anyone that has any questions. You can put it in the chat, or you can just kind of raise your hand and we can call on you and you can verbalize it to Heather. So here's Heather's contact info too. That's great. So questions from anyone. You can unmute yourself if you have a question too, verbally.
Well, I typed something in there.
Okay, here's one. Lisa says, is there any evidence for somatic mutations?
Ooh, that is so interesting, Lisa. I do believe there has been a couple of reports. I think Dr. Etheridge has published a report on this. So by somatic, It means you're meaning that like a change just in someone's eggs, but not in every cell in their body, or maybe just in the heart, but not in their blood.
I mean not germline. I'm asking because my mom has long QT and it's the KCNQ1 gene.
Mhm.
And I have 3 sisters and myself, and all 4 of us tested negative for that mutation at least.
Okay.
And my mom had 3 siblings, one who died young from unknown causes, and I think most of her children and grandchildren have been tested, and none of them appear to have any mutation. So I'm just wondering if something could have arisen in my mom that's not been passed on.
Yes, it's possible that she was a new mutation, that it spontaneously arose in only her, and that she did not pass it down to you guys because there's a 50-50 chance. The person in your family who died, I imagine they did not have genetic testing on that person.
No, it was like probably 60 years ago.
Oh, yeah.
And she had just had a baby like 4 weeks before and just died unexpectedly. And then after my mom was diagnosed and we started reading about it, that seemed to be one of the time periods or you could
Yeah,
have
it's
that happen.
a period of increased risk, the postpartum period. So that is suspicious that she might have also had a SADS condition. But I'm glad that you and your sisters got tested for her known mutation, that you're all negative. That totally can happen with each kid. There's a 50-50 chance. So it's possible she just didn't pass it on. So you're doing everything you should.
Okay.
So Aaron on our team put the link to Invitae's sponsored genetic testing program called Detect. So there's the link to the SADS webpage that talks more about that, and that's a free testing program. Carolyn asks, are all genetic testing companies the same?
Caroline, that's a good question. They are not all the same, and there are Alice and Marcia and the SADS team work very closely with a certain number of companies because they have looked into the company's offerings and how they work, and they can tell you specifically which ones they recommend. But there's actually a big difference between the diagnostic genetic testing companies for certain diseases like long QT and Brugada and ARVC versus genetic testing companies, the more fun recreational ones like getting 23andMe testing done. That's only looking at certain mutations for more fun things like earwax or like different silly things, how you metabolize certain things. And so if you were to look into this on your own, you would want to use one of the diagnostic testing labs that SADS recommends or your genetic counselor recommends. So different labs are definitely looking at different things.
And we actually have a link on our, we'll put the link for our website to all of those companies. There's 4 or 5 different companies that we have on our website. And so the contact information is there. So I'll ask Erin if she can put in that link. We have a question, another question.
I did just put that link up, sorry.
Okay, thank you. I think it's Claire, asked, you spoke about nucleotide in your discussion and reading about the genetic test. You didn't discuss the last part of that. This person's, I guess, from Massachusetts.
Okay, hey Claire. So let me just see if I can get back to that slide. So on that slide, I had put up the on your genetic test report, there'll be a C period, which is the nucleotide change. So the 4 letters in the genetic alphabet, which letter changed at what position. And then the P part is the amino acid change. So every 3 nucleotides codes for an amino acid. And so they will put the amino acid change denoted by P period, and then in this case it was phenylalanine to lysine. So does that answer your question?
I think so. Thank you. I just wasn't sure it was as valuable, I guess, as the first part, as the nucleotide that you would discuss.
Mm-hmm. Both pieces are important. They're just looking at like the first is the exact spelling change, and then the second is what amino acid that changes. It's a good question.
Okay. Thank you.
Mhm.
Okay, thank you, Claire, for your question. Any other questions from anyone? Karen, go ahead.
I was diagnosed at about 40 just randomly because I had bradycardia, and I was having a colonoscopy, and they wanted to they were afraid my heart rate was too low. So they put me on a 24-hour heart rate monitor, and I'm very active, and I've never had any symptoms. Everybody except for my mother and my grandmother, and I have a big family, died of we always said a heart attack in the 50s, 60s, or 70s for about 3 generations, as far back as we know, since people came over from Europe. And I just always thought in my head, that's my family lineage. Nobody ever mentioned cardiac arrest, and nobody had an autopsy after. And it was sudden. It was like, boom, end of game. And that happened to me. I said no to the ICD. I took the beta blockers, felt horrible when I was 40, got off of those, and then had a cardiac arrest 2 years ago. And fortunately, I was in the ER because I had just fainted, and I never fainted before. So it was like my first time I ever had any symptoms. It was a cardiac arrest. And I was lucky I was in the ER of a trauma 1 unit. So I'm here to tell you the story. But so in northern Vermont, there's a big hospital that's a medical teaching facility. It's a trauma 1 where I'm now seen. I had the procedure done in Denver, but because I was on vacation there, and nobody ever mentioned anything about genetic testing to me. So when I filled out these SADS forms, I just say long QT unknown, because I didn't even know there were different types of long QT. And my cardiologist is an electrophysiologist, and he's supposedly good. And I'm managed with the ICD and the beta blockers. But I had to really be assertive with a social worker to get them to get genetics counseling, which actually called me. I had to call them back today to get an appointment to even consider getting counseling, and testing. It's just not done up here. I don't know if it's regional or, different. It seems like it would be really valuable to know what type. I have a 30-year-old and a 34-year-old who have never had symptoms. My son was an Olympian, and he never had and he was a sprinter. So you'd think he would have had symptoms if he had it. And he seems to take after my side of the family. But my husband's, my daughter's like, you don't know. I can't talk my kids into being tested. So I figure if I'm tested and it comes back that it's one of the genetic types, that I can use that as will you please get tested? Because if you have a 30 or 34-year-old, you can't tell that age they're not kids. You can't make them do anything. I mean, their health is their health. You can't manage their medical. But that's my only reason going in for genetic counseling. Well, two reasons. One is I could use it as more forcefully to encourage my kids to get tested. And second, with COVID, I was reading about, and it's a little off topic, but they talk a lot about long QT2 and the mononucleic enzymes. And, I'm wondering if there's so many drugs that are not safe for people with long QT to take.
Yeah.
And will those drugs be, I mean, I'm just super careful about COVID and hopefully won't get it, but I live in the middle of nowhere, but it's high in Vermont right now. And if it's, I guess I asked my cardiologist if those medicines that they're coming out with, they say if you're high risk and you're positive, take the meds, but can you as with long QT? It seems like SADS would be a better place to ask, because you all seem to know more than I thought. The hospital up here and the department was good, but they didn't even recommend. I had a fight to get to see a genetic counselor.
Yeah, I mean, I think Karen, first, like, I'm so glad you're here and that you arrested in the emergency room. And I mean, you have the opportunity, like, you sound like a strong advocate. You're gonna be the one that teaches your electrophysiologist.
Well, I work in the health field, so
Okay.
I usually run groups. Yeah, so I'm used to being an advocate, teaching other people to be advocates for themselves. But I hate also having in my chart, it's a difficult patient, which will probably end up in my chart somewhere. It will say that you're
I think they would be like something that I encourage everyone to advocate for, and it should already be happening. But if you do see a genetic counselor, make sure that information is communicated back to your cardiologist or whoever your primary care doctor needs to know that you need to avoid QT prolonging medications.
Well, even my dentist, I just had an implant, and every time I go in, I say no epinephrine in the Novocaine, and he's like, "Oh, you're gonna get a lot of bleeding," and I'm very assertive to make sure, because I know epinephrine's one of the worst. But you really have to stay on top of it. So I was just wondering with these new COVID meds that they're coming out with, how that's going to play out with long QT.
I'm going to punt that to Alice because I know that there's been some Facebook Live discussion about this.
Oops, I have to unmute, sorry. Yes, we have had a couple of programs with both with long QT experts. We've had about 3 of them, if you go back and look, as well as with experts in, on the COVID side of things, about talking about what you need to know and what the update is. So you're welcome to that. Those are all free and taped in on our YouTube channel, so you can watch. But basically, I think at this point, not considering the brand new variant, everyone has agreed, as far as the SADS long QT experts around the world, that there is not any special issue right now that you need to worry about. There's none of the drugs that were early on a problem that they were using. They're not using those any longer. So those were, if you got COVID, you might get something that you shouldn't be taking if you have long QT. But even then, it was more about, you're going to be getting this in the hospital and you're going to be monitored. So if they really help, if you really need them, then that's fine. And like I said, those drugs are not being used now. And definitely everyone is recommending vaccination.
Yeah, I have all 3, but still, the governor speaks every Tuesday, and he was talking about in Vermont about them. If you're at high risk and you have COVID, get the mononucleic enzyme medication so you may not be hospitalized. So of course
Right,
it's
and I
a
think that is,
job.
again, a lot of people were looking at that, trying to do that, saying, is there enough or not enough? Now, of course, there's some new medications that are antiviral that are looking like they're really, really promising, not yet approved. So they're improving all of the care, I think, and that will prevent death. Basically, it will decrease the death. But again, as far as we know, as far as what we have heard from our experts, there is not a high risk group in the SADS conditions, except possibly in the cardiomyopathy side for ARVC. And
Right.
that, again, it just depends on certain conditions. That would be the only potentially higher risk. And even then, as far as those expert physicians and the Hopkins folks that we work with, they shouldn't be considered high risk in terms of, you know, COVID, basically, or getting
That's good to
vaccinated or
know.
anything like that. So
Yeah, I'm like, oh, great, another drug I can't take.
yeah, that's exactly right. I know. So
Okay.
Thank
Thank you, Karen.
Okay.
Thanks for your comments. And Carolyn has a comment to make. Go ahead, Carolyn.
Hi, my comment is basically, I guess, towards Karen and her kids. And I know they're older. My daughter is 24 and just on the 2nd of this month had 2 cardiac arrests. She's 24. She's a dancer. That's her profession. And luckily her fiance was there, turned around for 1 second to feed the cat. And the next moment, my daughter was blue. So thankfully she's here by just someone, you know, the father of her fiance just shook her. And then rushed, you know, the ambulance came and all that. And then she had that second episode at the hospital and they ended up, you know, taking her to Tufts University Medical Center. And thankfully, you know, they figured out what was going on a few days later. And she has a defibrillator and it's like one component and it hooks one on one side and one on the other side, each side of her heart. Pacemaker and defibrillator. So I'm really am looking forward to getting tested. I made an appointment with a primary because I just moved, so I didn't have one. So I'm a little anxious about getting tested and having everyone else in the family to get tested as well. So I really, really hope that your kids will get tested.
I do too, because they're both married and they wanted to have children.
Yeah.
So this is, you know, continual that it would be a risk if mine is, you know, I know at the, I think it was at the national conference, it was said that you're never completely negative. Like if I'm the first, I might show is that I'm not a strong genetic, I don't have a strong genetic component to pass it on, but I can. Like there's no absolute that I can't pass it on. Is that true?
Well, that's a good question. So the current testing is looking at, you know, 30 to 50 genes. Even if you have whole genome testing done, they don't know all the genes at this point that cause long QT. So if your test results come back without identifying a genetic cause in you that we can definitely say like, this is it. If they come back kind of uninformative, there's still 19,999 other genes that could be causing different problems. So what's really helpful is if you have a positive genetic test result, to be able to use that in your family. If you come back uninformative, then your kiddos should be tested by EKG and other electrophysiological testing.
That's what my doctor told me. Yeah. He said, just get them in for their physical until, you know, have them do an EKG, start it at that level. Yeah.
Yeah, that's a good point.
So David comments he was tested in 2018 at UVA, and he said, I heard you mention retesting, but when should I consider it?
UVA, did you happen to see a wonderful person named Matt when you were there, David? Matt Thomas?
Yes, he says, yeah.
Oh, good.
Okay.
I would reach out to Matt because he'll know the details of what testing you had done at that point, and if it's worth retesting.
You're muted, David. All right, can't hear you anyway. I can see your mouth moving though.
I'll say while you're still muted that you're in fantastic hands.
There you go. Okay, Laura makes a comment. My understanding is that genetic testing is used to determine drug metabolizer status. If this is true, can it be used to determine if a drug overdose was due to someone taking too much drug, or maybe, for example, not being able to metabolize and eliminate the drug?
That is a good question. So there are certain drugs. So I'll say there's two different ways of answering this question. So there's certain drugs with a long QT diagnosis where the QT can prolong, like the discussion we were just having about drugs to avoid. But there is also pharmacogenetic testing where they look at different genes. A lot of the genes have to do with how you metabolize antidepressants and clotting drugs or anti-clotting drugs. And that would be a different test than what we focused on. But in terms of an overdose of a drug, it would be that type of testing that would need to be pursued, is the pharmacogenetic testing. I don't know if I'm doing a great job of answering that. Does that help?
Yeah, actually, it does help. So I guess the type of testing is genetic testing, but it's for pharmacogenomics. Basically, how a person, is there a slow or rapid metabolizer is what I was thinking about. And then if somebody takes too much of it, or like the blood concentration is really high and there is a lethal outcome, you know, the question is, can you use the outcome of a pharmacogenetic test to help make a determination if that drug overdose was on purpose, like a suicide, or if it was an accident just as a consequence of someone using an appropriate amount of drug, but they weren't metabolizing it and the blood concentrations just kept increasing until the person died. That was just my general question. I didn't know if there's any information about that.
Yeah, I work like fairly closely with the medical examiner field, and I can't think of a case where they've specifically used that type of testing to determine cause of death. But it's an interesting question. They definitely test for different illicit drugs to see if somebody had like a high level of certain drugs in their system. But they're not routinely looking at like, was this person a good metabolizer of Zoloft, or that type of testing is not a regularly used tool in autopsies at this point.
I think.
Okay.
And
Thank
I
you
have
very-
two other comments for the two questions. I don't know, maybe you asked them and I didn't hear, but one of them is about using medications, specifically lidocaine or novocaine with the dentist. And so that's a question that we've had asked our advisors over and over in the last 20 years that I've been with SADS. And what we've always gotten is that nobody really sees any danger, has seen any danger with the dentist. I mean, we always say that's something you shouldn't use if you have long QT syndrome, but as far as dental procedures, there's not especially a high risk. We are in the process, and Marcia is coordinating that with our medical education committee, of getting a survey out, because we did have a couple of the docs ask about that, like, what is the practice now, and can we do something that sort of says what's the standard of care? So once we get that done and get that out to the physicians, we will definitely put that out to the community so you can see, you know, what the consensus is of standard of care for dental. So that's one of them. And then the other one is about genetic testing done a long time ago, in 1998 or 1999, and maybe through probably Dr. Keating's lab, if you were talking to SADS Foundation, although there was a couple of others. But in any case, I think almost everyone, and Heather, jump in, but we at SADS never have done any genetic testing. We don't have specific results per se, or we haven't been facilitating directly any of that through our history. But in that day and age, it was a real different genetic test. And really different, not only the methods and the way that they test, but also, of course, the mutation, the different variants that we now know may cause something or may not. Or so I think it would probably be appropriate to get retested. That's kind of what I would suggest. And most people say you keep checking in, you do periodically, because things change very fast sometimes in genetics. So chime in, Heather. Sorry, but
yeah, I would 100% agree. 97, 98, that was research genetic testing. And I would feel completely comfortable saying it's time to retest and confirm those research results and see. There's been so many additions since the late 90s, like looking for deletions and duplications, and it would really serve you well to be retested at this point.
Okay, I think we have one more question here from Abby. Our genetic testing has identified a gene mutation of unknown significance in her husband, SCN5A gene. And her husband has been previously diagnosed with ARVC. However, his electrophysiologist now believes, based on this gene mutation, that he may have Brugada syndrome instead. And he schedules a provocation test for this week. Does this seem like a sensible conclusion to draw from a gene of unknown significance? And we understand this cause also be linked to long QT, Brugada, or ARVC.
There's a couple genes that, depending on the mutation, can cause like just an arrhythmia syndrome like Brugada. SCN5A is like a major culprit of this. But it could cause dilated cardiomyopathy. It could cause ARVC. I'm curious, does he have changes in his heart muscle? Does he have a cardiomyopathy that you know of?
Abby, you can either unmute yourself if you'd like. MRI doesn't show any structural changes.
Okay. I think based on a variant of uncertain significance, they can't, that means like you're kind of like stuck in this gray space of it's a change that we don't know what it means, so it's not diagnostic. So they'll need to treat him based on the testing that he has and the symptoms that he has. And sometimes that's where we're stuck, because genetic testing is not a perfect science yet. And so they'll need to keep following him clinically. The genetic testing at this point is not going to help specifically tell you what he has. But I would recommend you keep checking back with who did the testing or with a genetic counselor to learn as much as you can about the variant. And if there's other people who are affected in your family, looking more closely at their medical records and their testing might help you continue to make sense of it.
Okay, thank you very much, Heather. We appreciate it. And thank you all for joining us tonight. We've had some great questions and we appreciate everything that you've accomplished here tonight. And thank you so much again, Heather.
Of
And we've had a
course.
lot of comments in our chat field. Thank you to Sads and to Heather. So we
Thank you.
appreciate it. Good night, everyone.
Bye, guys.
Bye.
Heather, hold on. You stay on just in a minute, okay?
Okay.
Got it.